Hello, and welcome to the Osteogenesis Imperfecta Foundation's monthly podcast. My name is Tracy Hart, and I'm the CEO of the Osteogenesis Imperfecta Foundation. On each podcast episode, the OI Foundation brings you information about the diagnosis and treatment of osteogenesis imperfecta and information that will be useful to the OI community. The podcasts are a part of the ongoing educational effort of the Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. The professional education activities of the Brittle Bone Disorders Consortium are led by the OIF. Our podcast today will feature Eric Gascho, Vice President of Policy and Government Affairs at the National Health Council. And we're going to discuss the Affordable Care Act today. Welcome, and thank you so much for being with us today, Eric.
Great. Thank you, Tracy. I'm happy to be here.
Great. So before we start, if you could just tell us a little bit about the National Health Council for those of our community members that aren't familiar with the NHC.
Sure. So we were founded in 1920 as a trade association for patient advocacy organizations such as the OI Foundation. And we do a lot of trade association work such as how to do business best and focus on issues such as governance. But we also do a lot of work around public policy. And joining us in these efforts are other members in addition to patient advocacy organizations, such as provider organizations, insurance companies, pharmaceutical companies, other nonprofits such as family caregiving groups. And it really means that we're bringing a lot of very diverse perspectives to tackle some pretty complex healthcare policy issues. Yet it's the patient groups that really control our governance. We're driven by our board of directors, which you know very well as a member of the board, to really keep a keen focus on what matters most to all people with chronic conditions. Our mission is to provide a united voice for people with chronic diseases and disabilities and their family caregivers. So we work on a lot of very complex but high-level systemic health issues, so things that impact all people with chronic conditions. And obviously, the Affordable Care Act is one of the key things that we've been working on for quite some time.
Great. Thank you for that. So the Affordable Care Act. We asked you today to join us to talk about the Affordable Care Act and potential changes you see happening now that the new administration is in place, and maybe what those changes mean to our community. But first, just so we're all on the same page, could you give us a quick overview of the ACA? I know we could use all our time talking about that, but if you could just, take a couple of minutes just to, so we're all on the same page before we start.
Yeah, I suspect that you're right, that we could spend an entire podcast talking about what the law does. So rather than, do that, I want to focus on some key constructs of the law, and then some more specific things that we think have a much more direct impact on people with chronic conditions. So broadly speaking, the law really made a lot of changes to the health insurance market, particularly many of them to the individual market, so people who are purchasing insurance on their own as opposed to getting it through their employer. And it does that by creating what are called health insurance exchanges or marketplaces that allow people to make side-by-side comparisons to purchase a plan that works best for them. Coupled with this, there are insurance tax subsidies that help people who are less financially well off afford their insurance. It does other things such as expand the Medicaid program to bring in a lot of new people based on bringing in folks that were a little bit wealthier than who we saw included previous to the ACA, as well as new types of people. So in many cases, that's where the largest expansions of enrollment we've seen have happened in the Medicaid program. Some of the things that people know pretty well that were changes that were made by the law. Children can stay on their parents' plans until the age of 26. Plans are required to offer annual wellness visits free of charge. So some of these things are probably a little bit more well-known and really impact a broad population. One thing, and then more specifically focus on people with chronic conditions, and this is kind of the thing that people seem to forget when we call it the Affordable Care Act. The full name of the law was the Patient Protection and Affordable Care Act, and I think as we move forward, it's really important that we key in on some of these patient protections. I think that's really where the law has been successful. I think on some of the issues around affordability, we've had some challenges, and so through this effort, I think we can work to address some of those challenges. But in terms of some of the patient protections that we saw included in the law and are keenly focused on making sure remain through this exercise, one is the pre-existing conditions exclusions. Previous to the ACA, insurers were able to exclude people who had pre-existing conditions, or they could charge them a higher premium based on their condition, or in some cases could drop people from their plan if they were diagnosed with a new condition. And under the ACA, this is no longer allowed to happen. There are some other benefits that people with pre-existing conditions, particularly ones with more costly conditions, have. So it removed lifetime and annual limits to people's benefits. Prior to the ACA, many plans had limits on the amount of benefits that you could receive either over your lifetime or in some cases in 1 year. The law also caps someone's out-of-pocket costs. So when you think about these, we're talking about deductibles, co-pays, co-insurance, those types of things. There's now a hard cap on the amount that someone can have to pay their insurer in terms of their out-of-pocket costs. One other thing that's included is what's called the essential health benefits, which is a set of services and other benefits that plans must cover. So this is something that looks different in every state, but there are requirements that plans have to have a certain floor of the benefits that they have for people. So that's sort of in a nutshell. As you said, we could talk about this all day. It's about a 1,000-page piece of legislation, but in terms of some of the things that we're keenly focused on, those are them, and we'll continue to see what happens under what we see coming in the next few months or so.
So just to thank you for that. That was a really good overview. And just so we're all, sure what we're talking about is these provisions were for everybody's health insurance, not just insurance that was purchased in the marketplace. So this was legislation that affected if you were employed and you got your insurance through an employer or you purchased it on your own, correct?
That is correct, yes.
Okay. So here we are, and the ACA, the Affordable Care Act, will be repealed, correct, which will happen. And what could the replacement look like, focusing on what might affect people with a rare disorder like OI, Eric? What are some of those scenarios?
Yeah, and I like that you frame it as what could happen. I've been getting a lot of questions lately trying to figure out what exactly is going to happen, and this seems to be something that changes by the day, but I will go ahead and give my best guess of what's going to happen as of February 21st at 4:08 p.m. With the understanding that things could change very rapidly.
Right.
So we've seen a lot of different proposals put out there from a variety of different members of Congress. And we're starting to see some themes emerge, which has been good to see in terms of being able to make better predictions of what to happen and try to figure out where it is that we need to be plugging in and what are some of the things that we really need to be focused on in this effort. Some of the things that we are seeing, there's really two main things that I think are going to happen. One, there's going to be a focus on capping federal spending and cost growth. So some of the things that we've seen in that area around the Medicaid program in particular is trying to set a hard cap on the amount of money the federal government will pay into the program. Another thing that we've really seen emerge as a theme across all of the different proposals is offering more flexibility to both states and to and to insurers as well. So that's something that I can see good reason to do both of those things. I think particularly at the state level, I think in many cases all states are different. So giving some flexibility there I think is important, but with some, in an ideal situation for me would be to do that with some federal guardrails around what they can and can't do. Same thing with insurers. One thing, as you listen to me talk, many of the things I've been talking about and will continue over this podcast are many of the things that we like about the Affordable Care Act, particularly the patient protections. But I have to be completely honest and say that there have been some issues that have certainly arisen from it. This gives us an opportunity to address them. And I think through some regulated flexibility, I think that can help in terms of creating more stability in the marketplace than we've seen over the last few years. We've been looking at a variety of different possible scenarios basically since President Trump was elected in November. First, we heard that they wanted to repeal the law and then put in a 2 or 3 year period in which it stays in effect, and then give them an opportunity to come up with something to replace it with. This created a lot of concern from a variety of stakeholders that it would create a lot of instability in the marketplace and allow people to fall through the cracks in the meantime. And luckily, we've seen that idea kind of fall by the wayside. Then we've heard the idea of repealing and replacing immediately, which I think we're getting closer to. So there's repeal and delay, repeal and replace. What I'm starting to see sort of emerge is what I'm calling repeal and reframe, or repeal and rebrand. And that's that I think a lot of the general tenets of the Affordable Care Act, particularly around the things that we care most about, are likely to stay in place. So when I say that, what we've been most keenly focused in and really want to drive the point home is that we can't go back to the days before the ACA in which insurers could keep people out of their plans because of their pre-existing condition or charge them a higher premium. And luckily that's starting to emerge as something that both sides of the aisle are in agreement on. And so that's something that we've been really happy to see. At the end of the day, no matter what happens in this process, the bar has been set much higher than it was before the ACA. And that's really important to remain focused on it and consider that a success. Some of the other things that we're seeing them potentially reframe or shift the way they do it. One thing people may be familiar with is the individual mandate. So this was included as a way to drive more healthy individuals into the marketplace to offset some of the costs from people who have more expensive conditions. And this is something that we will very likely see go away. I would say it's almost a certainty. But there needs to be something included that is going to encourage people, younger, healthier people, to purchase insurance. So many of the people who haven't really seen a need for insurance in the past, which would be very unlike the people that we represent, people with chronic conditions, understand the importance of health insurance. So how do they drive them in? And one thing that has emerged as a possibility there is what they call continuous coverage requirement. And so what this would look like is you're not going to get dinged every year for not buying insurance like currently happens. But what would happen is when you do decide that you need to enroll in an insurance product, that you would pay a sort of late enrollment penalty. It's similar to what happens in Medicare for people who don't purchase a Medicare Part or enroll in Medicare Part B or Part D. So it would really incentivize people to sign up now and not wait later. And if they do wait later, that will help offset some of the costs of more costly populations. So that's one thing that would be a slight change, but looks to accomplish the same goal. Another one that's starting to emerge is what are called invisible high-risk pools. And I'm going to try to speak about these at a high level, but I know that they're probably going to, people haven't heard of them now, they will be soon. If anybody was in a high-risk pool before the ACA, they know there were a lot of challenges associated with them. So what they had done in many states was for people who couldn't purchase insurance because of their condition, were able to buy them off of a high-risk pool. And those they had waiting periods, the plans were more expensive, they had a lot of limits on their benefits. They really didn't work well in the vast majority of states that had them. And so we want to make sure that we're not segregating high-risk individuals and low-risk individuals. And luckily we're seeing that they want to keep them all in the same risk pool. Then how do you then offset some of the costs? And so what they've talked about is creating a fund that would go to states to pay, and they would be able to use them as they see fit, and help offset some of the costs for plans that have enrolled a higher cost than average population. And we think this could be something that would be a really meaningful benefit, because I think that it could result in lower premiums for many people and really create a lot more stability in the marketplace. I think there's a lot of questions that arise in terms of how those would be operated, what the funding would look like, those types of things. But I think as a general concept, it's something that we see as a promising thing that's starting to be discussed. One of the other things that we think there's going to be a lot of attention to is the funding that currently goes to people to help offset the cost of insurance. So currently it's income-based, so generally speaking, the less well-off you are, the more funding the federal government is paying you to purchase insurance. So this is something that I think we'll see some changes made to the way this is done. Could give me some concern, depends on how it will be structured, but it seems that a lot of that will be based on age as opposed to based on income. And the reason for this is that they are also talking about potentially charging higher premiums for the older you are. That currently is allowed under the ACA, but they're talking about broadening that more. Currently, the oldest person in a plan is not allowed to pay more than 3 times as much as the youngest person, but they're talking about making that 5 to 1 instead of 3 to 1. So someone who's just approaching Medicare eligibility could pay 5 times as much as someone who's 27 years old. So that's something that they would try to offset that by giving them more funding. So that's something that we could see be shifted in terms of how those subsidies are structured. One of the other things that we're really looking at is what's going to happen with Medicaid. That's something that, as I mentioned earlier, as part of the ACA, was expanded to bring in a lot of new people into the Medicaid program. There's been a lot of talk of doing these programs differently. There's something that our now Secretary of Health and Human Services had proposed when he was a member of Congress last year that would give a set amount of funding to the states and let them sort of best determine how to run their programs. This would potentially create a lot of winners and losers in terms of different states. So it'll be interesting to see how they do this. I think what we could see is the House of Representatives, who will probably pass something before the Senate, pass some serious changes to the Medicaid program, and then when we get to the Senate, I think it would be a different dynamic. The margin of error is much thinner for the Republicans there, and if there are senators in particular states that expanded Medicaid and are getting a lot more federal funding that they would then lose, I think it's going to be a difficult political situation for them. So, playing on this theme of politics versus policy, it's going to be an interesting thing to watch. One thing that I should have mentioned at the beginning is that none of this is going to be instantaneous in the way that I'm sure some people are really concerned about. I cannot foresee them passing something that repeals the Affordable Care Act and automatically means that someone who's benefiting from it now will lose their coverage. That's simply not a feasible or a viable way for this process to play out. People may have heard there was a leaked audio recording from the Republican conference a few weeks ago in which many members of Congress expressed that concern. I think the phrase that we've heard over and over again is that we don't want to pull the rug out from under people. So rest assured that this won't be something that's going to happen overnight. I think it's going to be a long-term process. And as I mentioned, there's a lot of patient protections that we have been very supportive of, but there were a lot of issues that were created as well. And I think that this gives us an opportunity to try to address some of these issues while still remaining true to our mission and still making sure that we protect patients as much in this process as possible.
I think that's really important what you just said there, Eric, and thank you so much for that. It was really, really informative, is that it could be an opportunity, and we need to look at it like that and to make sure that we're protecting our communities as best we can and moving forward with our missions. We only have a couple of minutes left, but I had a quick question for you because you mentioned a couple of times, well, probably 3 or 4 times, that this would go back to the states or the states would have more flexibility. If you're living in a state, how do you find out what your state, what kind of flexibility your state will be having with anything that's new? Is there a certain department that you call or a website? I mean, how do you know state by state?
Yeah, it's a difficult one, and I know it's difficult for a lot of patient organizations to deal with this too, because a lot of what this means is we go from a one audience message to a 50 audience message or more when you consider D.C. and Puerto Rico and all the territories. I would be remiss to say if a lot of this flexibility doesn't already exist. The states have been regulating insurance for basically since the beginning of insurance. But I think that this does create even the efforts that are being taken creates even more areas for them to look quite a bit different. And so, I think it's it depends on the state that you live in. Currently, a lot of questions that you can have answered from the state exchange, or there are navigator services there to help steer you in the right direction. It might depend on what program you're in. If you're in Medicare or Medicaid, there are ombudsmen. So there are a variety of different avenues. One resource that people may have to figure out what's happening in their state is the National Association of State Health Policy, NASHP. They do a lot of really informational webinars, and they have a lot of resources that look more specifically at each of the states. Same thing with the National Association for Insurance Commissioners. So there are certainly a lot of resources out there that would probably be much more knowledgeable than I am on what's happening in your particular state.
Okay, and we'll continue to look to you, Eric, and the National Health Council to help us, as we move forward in this process. And we'll put some of those resources up on our website as well. So this went so quickly, but thank you so much. This was so informative. Any last words for our 30 seconds we have left?
Sure. Go to our website, nationalhealthcouncil.org/health reform. We have a lot of resources that we're updating on a regular basis. We have a social media toolkit for those who are active on social media to really talk about the protections that they are concerned about. We'll be sending out an action alert for people to contact their members of Congress. The next one is going to be on protecting the maximum out-of-pocket limit. That's one thing that we haven't heard a lot about in some of these efforts, but know that it's a really important patient protection for people. So we're encouraging people to call their members of Congress to make sure that that one makes it through this effort, and we'll be updating that as we go along and really focused on specific policies that we want to make sure that members are hearing from their constituents that they're important to them.
Well, terrific. Again, Eric, thank you so much. In addition to the National Health Council website, you can always visit our website at www.oif.org. So thanks again, and we'll be talking to you again, I'm sure.
Great. Thanks, Tracy.
Okay.